rounds. So today's theme is going to be critical care cardiology. And before we go into our speaker and introduce her, I'm just going to share the details for tonight's CME and MOC requirements. And you will be able to see this presentation on the website. And for the CME credits, please text 20383 to number 888-816-4893. 20383 to the number 888-816-4893. And for the MOC points, please complete the step 1, and this link will be provided again. And you can use the room code future57. So please complete the CME credit, and then the MOC for physicians. You can use it by using the room code future57 for the link that will be provided again in the chat field. All right, so with that, it's my pleasure to introduce tonight's speaker, Maria Karras. Welcome, Dr. Karras. Dr. Karras is Assistant Professor of Medicine in Will Cornell Medicine, Division of Cardiology. She completed her undergraduate education in University of Pennsylvania and a medical degree from Will Cornell Medical College of University. And subsequently, she stayed in New York, completing her training in internal medicine, cardiovascular diseases, and completed also a subspecialty training in advanced heart failure and transplant cardiology. During her residency and fellowship, she has performed clinical research in the areas of stroke, imaging, and heart failure. She was awarded the ACC Foundation Merck Research Fellowship in 2012 and has been prolific in her research and peer-reviewed publications ever since then. She joined the Weill Cornell Medicine as a full-time faculty in 2013 as a member of the Perkin Heart Failure Center, and with her clinical interest in heart failure, pulmonary hypertension, and mechanical circulatory support. Dr. Karras currently serves as the medical director of the Cardiac Intensive Care Unit and also the director of the NYP Weill Cornell Cardiogenic Shock Team. And I was trying to discuss with her what brought her to this field, and her answer was she enjoys doing it. And believe it or not, for folks who are here, my young faculty members and also my trainees, I asked her how many weeks she's on service, and she told me that she's on service about 20 to 22 weeks in a year. And I asked her, does she not feel burnout? And her answer was that no, she enjoys it. So I think the passion and the enjoy, if you like doing something, it's the best way to look into how the current academic structures and how we are really facing the burden of heart disease and critical care areas are currently a shortage. And while it is very exciting to learn the phenomenal advances that have happened, it is equally important that we are tuned to the our inner call, and we enjoy what we try to do, because that's the best way to make the best use of our time and energies. With that, Maria is today going to focus on a talk on critical care, cardiology, and also give us some insight about cardiogenic shock and other areas of interest. And I think it'll be very exciting to understand what's happening in NYP in New York and the growth that's been happening there. Thank you very much. She was introduced to me by my very close friend and colleague, Jonathan Weinsaft, who was here also as a presenter in our grand rounds of several months back for the imaging presentations. So with that, Maria, we'll look forward to your presentation.
Thank you, Dr. Sengupta, for that gracious introduction. So I'm going to share my screen. Okay. Okay, hopefully you can see my slides here. So So today I'm going to be speaking to you, about one of my passions, which is cardiac critical care, and really go through, what has happened over the past several years and update us on what the current landscape is in the cardiac ICU. So over the next 45 minutes, I hope to share with you the history of the CCU, what we're seeing now in terms of the diversity of clinical conditions and how we are attempting to staff our current ICUs, discuss the integration of cardiogenic shock teams, and ultimately finish up with how we're going to be training our future critical care cardiologists. So just a little bit more background about myself. I am a heart failure cardiologist, and I have always really been enamored with critical care cardiology, and I always enjoyed my rotations, even as a fellow in the CCU. And I was asked to become the medical director of the CCU in 2018. And at that time, I have to say, I started to delve into a little bit of the history of the CCU, wanting to know, where things came from and where we were going. And I've had the honor of working at New York Presbyterian, which was the home of one of the first CCUs in the country. So this concept of CCU began in the 1960s. And just to put us in that time frame, back then, the main thing that was being addressed was the treatment of acute MI. And primarily, patients were placed in oxygen tents on large mixed medicine wards. There may have been a bedside arrhythmia monitor available. And the main treatment really was bed rest, warfarin. Patients received morphine for pain and nitroglycerin. And unfortunately, the in-hospital mortality, if you were admitted with this condition, was somewhere between 30 and 40%. So the concept of the CCU was actually first published in 1961 in Circulation. And at that time, it was described as a technology-inspired extension of the general intensive care unit. Also, just to frame our minds, this was also around the time when we had the manufacturing of the closed chest defibrillator. The external pacemaker was also made available, and CPR was starting to be integrated, not just in the hospital, but with EMS. So here at Cornell, Dr. Killip and Dr. Kimball published back in 1967 their first 2-year experience in the CCU. And what they had created was a 4-bed CCU in a 39 by 19-foot room. And they provided the following equipment. They had continuous ECG monitors for the patients. They had oscilloscopes with an alarm system that was sensitive to changes in heart rate. They placed a defibrillator at the bedside of each patient, and they had emergency drugs and equipment. They staffed this little CCU with one specially trained nurse that was present at all times, 1 attending physician, and 2 interns and 1 resident. And again, their main treatments at the time was oxygen, bed rest, warfarin, and sedatives. So what you can see here is that there was a variety of presentations for the patients being admitted to the CCU, with the vast majority not being in shock. But you can see that many of them came in with pulmonary edema. They had incidents of arrhythmias, things that we normally see after acute MI. After the first 100 cases, they went to see how their mortality rates were that they had now created this small little CCU. And they were a little bit dismayed to see that the mortality was still about 26% for all comers being admitted. So at this point, they took a step back and thought, how can we reorganize ourselves? And at that time, it was really only that the physicians were defibrillating patients. The nurse was watching the oscilloscopes and the ECG monitors, but then she was contacting the physician team to come to the bedside. And as you can all imagine, this may have taken a lot of time. So what this group did is that they decided to empower the nurse to not only watch all the monitors, but then interpret the monitors and defibrillate the patients without a physician order if he or she noted VTAC or VFib. And what they noticed then is that they saw that the patients who were admitted to the CCU without shock, their mortality rate dropped from 26% down to 7%. So here are some pictures of what it looked like back in that time. And I actually had Some of these were being discarded when they were renovating part of the cardiology wing, and I was able to save these and brought them to my office. But over time, the CCU has changed, and we can see here from a study that was published from Duke University, looking at cases that were admitted between 1989 to 2006, that the rate of STEMIs that were being admitted was decreased, but what we did see was that there was an increase in sepsis, liver failure, patients needing mechanical ventilation, and those needing bronchoscopies. And what it started to look like was some of these CCUs were starting to look more and more like the medical and surgical ICUs. And physicians were noticing that the complexity of these patients was increasing and their need for critical care interventions also was increasing. Fast forward more to today, as many of you know, the CCU and the medical ICU have many things in common. Taking care of patients with respiratory failure, renal failure, heart failure, those that need critical care needs like mechanical ventilation, dialysis, vasoactive meds. But as we know, the CCU tends to have a lot more things like shocks, arrhythmia, and we have a lot more use of different devices, specifically in the realm of acute mechanical circulatory support, as opposed to the MICUs that's dealing mostly with sepsis, bleeding, complications of cancer treatments, and chemotherapies. And so as we know, as we go further and the technology within the realm of cardiology continues to spring forward, we're going to see that probably more and more devices are going to be housed in our CCU, and we're going to diverge even more so from our MICU colleagues. So if I think back, I've really had the opportunity to see our CCU change here at Cornell. As you heard, I actually did all my training here and have spent nearly 20 years at this institution. And so I can tell you that when I was a resident, I certainly did not see all the things that I'm depicting on this slide here. But now when I walk through our CCU, I see a lot of Swan-Ganz catheters, balloon pumps, Impellas, durable LVADs, patients that have undergone many different types of structural heart procedures, and also emerging patient population of those with adult congenital heart disease, as among other things like immune checkpoint myocarditis. So many people have felt, that maybe it's time now for us to start changing our name from CCU to a cardiac ICU. So we learned a little bit more about what is going on in the ICUs here through the Cardiac Critical Care Trials Network. This is a collaborative research network of many advanced CCUs in the United States and Canada. And initially, when this group came together, this is run out of the group up in Boston, 16 centers participated. These are mostly academic medical centers that had cardiology-led or ICU-based physician staffing. And each of these centers contributed consecutive CCU admission data for a 2-month period. And what we started to learn here is that the current ICUs were mostly dealing with patients with cardiac problems, but there was still a small percentage of patients that either were here for general ICU needs, NICU overflow, some post-surgical care, or had things like interventions like needing frequent glucose checks or neuro checks. But what we started to learn here is that the amount of ACS we were taking care of, despite it being about 1/3 of all of the admissions, we're seeing more and more things in the realm of heart failure, many different types of arrhythmias, and all other types of cardiovascular diseases such as valvular disease, aortic syndromes, hypertensive emergencies, tamponade, pulmonary hypertension, and again, the adult congenitals. In addition, when we look at the reasons for admissions to the CCU, not only do these patients have primary cardiac problems, but they are also respiratory insufficiency, need for vasoactive meds, need for other renal replacement therapy, or here with neurologic emergency. However, there still is a proportion of patients that are there for post-procedural observation or have the need for frequent monitoring or laboratory testing. When you contrast this for the mortality rate of patients, what you can see is that the patients that are there mostly for post-procedural observation or frequent laboratory or monitoring have very low mortality compared to the patients that are being admitted for neurologic admission, for respiratory issues, for renal replacement therapy, and obviously cardiogenic shock and cardiac arrest. So knowing that the percentage of patients being admitted to the CCU for acute MI has decreased, many people wanted to take a closer look at what were the mortality rates for these patients coming into the hospital. And they made a comparison between patients with acute MIs that were being admitted to CCUs versus those who were being admitted to either a step-down unit or to the ward. And what we can see is that there does not seem to be a big difference for patients being admitted either to a CCU or a step-down unit, but there may be a difference in putting those acute MI patients on a general medical ward. So what lessons have we learned from here? What we have learned is that for acute MI care, what we do need is to have the availability of centralized continuous ECG monitoring, of trained and experienced nursing staff that can recognize arrhythmias on telemetry and initiate therapy in an emergent fashion, be able to perform external defibrillation and CPR, and have a coordinated specialty-focused process of care. And for many of these academic medical centers, our step-down units may be more than capable to be able to take care of some of our low-risk acute MI patients who do not have major complications like shock or mechanical complications. And so there's been a proposal in the field to re-triage these low morbidity and low mortality patients to lower levels of care so that we can prioritize and use our ICU beds for the sicker patients out there. Some of the other lessons that we've learned from the Cardiac Critical Care Trials Network is that about 60% of the admissions that are coming in do require advanced ICU therapies. And many of these patients that are going to require things like advanced respiratory therapies, invasive cardiac hemodynamic monitoring and management, use of mechanical circulatory support devices, will have some of the highest mortality and lengths of stay. So this is really starting to highlight the need that clinicians that work in the cardiac ICU not only need to have the expertise in managing cardiac disease, but also need to be very familiar with critical care needs such as mechanical ventilation and continuous renal replacement therapy. So this now begs us to look a little bit closer into how we're staffing ICUs. So I'm going to take a step back. This is a study that was published about 20 years ago that was investigating how staffing in the medical ICUs affected hospital length of stay and mortality. And so what these authors looked at was they compared ICUs that had a low intensity staffing model compared to those with a high intensity staffing model. The way they defined a low intensity model is that there was no intensivist present or that there was an elective intensivist consultation. They compared these to the ICUs that had a high intensity model, which required a mandatory intensivist consultation, or it was a closed ICU that was solely run by an intensivist. And what you can see from the plots on the right-hand side is that the high intensity staffing models were associated with lower mortalities and lower length of stay. So how can we now take a look at our cardiac intensive care units? So this is a study that was published out of Seoul in South Korea at one of their large academic medical centers. And what they did is that within their own single hospital, they compared and contrast their mortality and length of stay when they had a low intensity model and then compared it to when they switched over to a high intensity model. So their low intensity model was 3 senior residents that cared for patients under the supervision of each patient's general cardiologist in a 12-bed cardiac ICU. And what they did is that they compared this to their high intensity model in which the residents, these 3 senior residents, rounded with a cardiac intensivist who supervised the care for all the patients. So in other words, they closed their ICU and had a single attendant for everyone. And what they found over time is that they reported a reduction in their ICU mortality their hospital mortality, and their mortality due to cardiovascular causes, non-cardiovascular causes, sepsis, and bleeding. So in 2012, the AHA published a scientific statement that outlined this emerging need for new medical staffing in the cardiac ICUs. And what they did is they proposed 4 different staffing models, which they recommended that hospitals adopt. One staffing model included having the shared responsibility with a consultant intensivist. So here you could have a semi-open model in which cardiologists and intensivists co-manage patients. And the advantage of this kind of model allowed for flexibility depending on your patient acuity, meaning if you had a really low acuity or low risk patient, the cardiologist would take the lead. But if you had a more high acuity patient, then you would have involved your intensivist even more. Obviously, the success of a model like this really depends on the effective collaboration between the cardiologist and the intensivist. Another proposed model was to have dedicated cardiac intensivists. And essentially, this means having a closed ICU model where a single attending or an intensivist would provide care for all of the patients. And here, ideally, your intensivist has expertise in both cardiovascular and critical care medicine, and is experienced in leading a multidisciplinary team, and is either present or available for consultation 24/7. Another model is to have an integration with other ICUs, and many hospitals have adopted this, where they have a multi-specialty ICU. And so here you may have one intensivist that is then working collaboratively with subspecialists, such as the cardiologist, pulmonologist, the surgeon, whatever that combination of patients are. And then finally, there was a proposal for service line ICUs, meaning where you have an ICU and group patients of a similar diagnosis together throughout their hospitalization. An example of this might be having an advanced heart failure ICU. In addition, in this scientific statement, they talked about being able to characterize the type of ICU that you have. This is similar to how we grade trauma centers or stroke centers and split it up into level 1, level 2, and level 3. With a level 1 cardiac ICU being able to manage all forms of cardiac diagnoses, including advanced heart failure and CT surgery, have all forms of invasive and non-invasive monitoring, including PA catheters and echocardiography, have access to all forms of different devices, including mechanical ventilation and renal replacement therapy. And those ICUs being staffed by either a single cardiac intensivist or a general cardiologist paired with a general intensivist. In addition, we want to remember about the nursing ratios, and in a level 1 ICU, the recommendation was either 1:1 or 1:2 nurse to patient ratio. As you can imagine, a level 2 ICU can do most of these things, but may not have as much access to all of the invasive monitoring or different devices. The nursing to patient ratio may be a little bit lower. And finally, a level 3 ICU would be defined as an ICU that could do some of the initial diagnosis and management of low complexity cardiovascular diagnoses, and that this ICU really would only have access to things like A lines and mechanical ventilation. So that statement was published 10 years ago by the American Heart Association. But let's see now more recently, what is going on in the US in terms of the cardiac ICU. So here, one of the Get With The Guidelines surveys had gone out to about 1,900 different hospitals. They collected 612 responses. And you can see that the breakdown here was 2/3 of the responses came from community hospitals, about 19% came from tertiary care non-academic centers, another 19% came from academic tertiary care centers. And of those academic centers, you can see that at this moment in time, about 2/3 of the cardiac ICUs were labeled as open ICUs, with a little over a third being closed ICUs. And here we can take another look to see how everybody has organized their cardiac ICU. So you can see that some institutions have mixed their cardiac ICU with their SICUs, or their cardiac ICU with their medical ICU, with actually only a relatively small proportion, around 8%, being cardiac only. In terms of the physician leadership, you can see there also is a variety of models that are being practiced out there, with about a quarter of them having a general intensivist, about 15% either having a true cardiac intensivist or a cardiologist who has more than 10 years of ICU experience. A little over a third had joint models where they had a cardiologist paired with an intensivist, and still about 11% had just cardiologist only run ICUs. You can see here there is still a variety of the number of NSTEMI admissions that are admitted across the board. But when we look overall at the number of the cardiac intensivists that are out there, there's not that many of these true dual board certified physicians, and you can see that they've really only manned about 15% of the ICUs. So what we've really seen is an evolution over time. If we go back to our little 4-bed CCU, you can remember there that the focus really was post-MI care, focusing on rapid defibrillation and nurses as first responders. And then things started to expand when we were looking at other types of cardiac patients, including those with arrhythmias, other types of structural heart disease, and having more of a specialized nursing and more broad approach to the cardiac disease, to coming up to present day, where we have patients with all different forms of cardiac disease. We have access to many different types of critical care interventions, acute mechanical circulatory support, and really having the need to have, advanced nursing teams and multidisciplinary teams that take care of these medically complex and critically ill patients. So I'm going to switch gears a little bit here and talk a little bit about shock and how shock teams are integrated into the present day ICU. So if we talk about what is the traditional definition of shock, it really is the combination of 4 things: patients who are hypotensive, those with diminished cardiac output, who have elevated filling pressures, and evidence of end organ dysfunction. This is a classic slide that published by Judy Hockman back in 2003 of what we think about the pathophysiology of cardiogenic shock. And the classic teaching, when I was a medical student, was that there was some type of insult to the myocardium, whether that was an infarct, myocarditis, and this led to decreases in systolic function, which led to decreases in cardiac output, decreased systemic perfusion and hypotension, worsening ischemia from poor coronary perfusion, and ultimately a vasoconstriction, worsening pulmonary edema, and hypoxia. And unless something was done, ultimately led to multi-system organ failure. But what we know now is that not only do all of these things occur, but we're also leading to systemic inflammation, the release of inflammatory cytokines. And we all know that if we don't intervene early in cardiogenic shock, we can then progress to more severe stages of shock where we see more of a hemometabolic shock and ultimately may see some vasodilation as opposed to just vasoconstriction. And understanding the left-hand side of this diagram really has led to the innovations here with shock teams. So back in 2009, a multidisciplinary group got together to really define a more granular definition of cardiogenic shock. And I think most people now are familiar with the SCAI shock stages. And this really was a collaboration between interventional cardiology, heart failure, cardiac surgery, critical care, emergency medicine, and nursing. And we defined shock now in many different stages to really encompass this wide spectrum of patients that we see, going from the patients that are at risk for developing shock, defined as stage A shock, to then those patients who are starting to become hypotensive but not having end organ dysfunction, to those that are requiring vasoactive drips or potentially devices, those who are then refractory to these therapies, and ultimately those that are either peri-arrest or actually arresting. And what we've learned is that not only are these a great way for us to communicate amongst each other as healthcare providers, But in retrospective studies, investigators have validated that there is an association between the sky shock stage and mortality. And this has been shown in different shock trials, other registries looking at cardiac patients in the ICU, and even those that have out-of-hospital cardiac arrest. More recently, this data has also been prospectively validated. And not only have we learned that identifying what shock stage the patient is at arrival helps us to decide on some of the next treatments, but that reevaluating these patients on a very frequent basis and seeing what their trajectory would be also is very predictive of what their long-term morbidity and mortality will be, and again, may help to influence what type of interventions that we're using. This is here an example that was published by Dr. Baran and his colleagues, looking at a single center where they examined all of their patients with shock that came in over an 18-month period. And what they found was that those patients whose sky stage improved within the first 24 hours really had the best long-term outcomes compared to those whose sky shock stage either stayed the same or worsened within the first 24 hours. And really, this was independent of the type of MCS they received or some of their blood tests. So in 2022, the sky shock stages were updated. And here, there wasn't a lot of specific changes in terms of the description of each stage, but the authors here did make a point that this is now a gradation of a pyramid as opposed to just different buckets that each patient was put in. And I think this really more reflects that this is a fluid state and that patients may change from hour to hour. And this is again, just trying to re-emphasize the need to continuously reevaluate these patients and see what will be the next steps for their treatment. In addition, with this iteration of the sky shock stages, they also added the modifier for those patients that had cardiac arrest with concern for anoxic brain injury, as we know that those patients have a different trajectory long term. So let's take a closer look at who's coming into the cardiac ICU in shock in the current day. So this is more data that came out of the cardiac critical care trials network. And when they looked at all of the patients being admitted to the cardiac ICU with shock, they found that about 2/3 of the patients were there with cardiogenic shock, but there was a mix of other types of shock in there as well, with about 7% showing distributive shock, 3% with hypovolemic, and 20% with mixed shock. But when we look closer at all the patients with cardiogenic shock, not surprising knowing that the amount of acute MI has also decreased in the cardiac ICU, you can see that the amount of acute MI shock comprised about 30% of the volume of patients being admitted, with the rest of the patients having shock of other causes, whether that was ischemic without MI, non-ischemic causes, other things like arrhythmias or valve disease. And so this really, this also is another marker of how the landscape in the CCU has changed over time. In addition, for all of us that have been working in the ICU, I think that there's greater and greater understanding that acute MI shock is not the same thing as heart failure related shock. And so many of the definitions that we've derived for shock really do come from the acute MI patient population. But not all of these things have been validated for the patients who have acute and chronic heart failure. And what we know is that heart failure patients oftentimes are walking around in either this pre-shock or pre-cardiogenic shock state, or maybe walking around with a low cardiac output at all times, not quite having end organ dysfunction. And so for me in my practice, it's not unusual that I might see one of these patients in the office and then see a patient that was not too dissimilar but has decompensating in the ICU. So the acute MI patient we know oftentimes is doing well and then has this event and they suddenly spiral, as opposed to the heart failure patient, which may be slowly sliding and then eventually has something else that tips them over and pushes them into the ICU. And so in this graphic here, we can superimpose all of these different ways that we categorize patients, whether that is our clinical classifications, our ACC-AHA staging, our NYHA classifications, Intramax profiles, and as you can see, the Sky Shock stages. And what we're learning more and more is that the phenotypes that patients present with in terms of heart failure cardiogenic shock, do seem to be quite different. We can see patients that are non-congested, those that have a predominant cardiorenal phenotype, or those that have more of a cardiometabolic shock type phenotype. And there's many people that are investigating how to better identify these patients, how to phenotype them better, and understanding then how we could use this information to then choose the optimal treatment strategy for them. If we compare and contrast again acute MI shock with heart failure related shock, what we can see here is that our acute MI patients tend to be older, have higher incidence of diabetes, have increased need for vasopressors, and have a higher rate of cardiac arrest. And oftentimes their hospital course is marked more by temporary mechanical circulatory support, have major bleeding events, and have vascular access complications. As opposed to those that come in with heart failure cardiogenic shock, those patients tend to have much lower ejection fractions, have lower cardiac power outputs, much higher pulmonary capillary wedge pressure, because oftentimes they've been living at a high wedge pressure for some time, and now that increases even further, and have higher pulmonary artery pulsatility indexes. These patients, their hospital course tends to be marked more by the increased use of durable mechanical circulatory support, requiring needs for the evaluation of heart transplant and go on to a heart transplant and have longer lengths of stay. And when we compare and contrast their cumulative mortality, you can see that up front, the patients with acute MI shock do have higher mortality in the early portions of their hospitalization. And then you can see how the curves would go out over the course of a year. So ultimately, when I'm teaching the fellows, I really try to impart on them what the goals are when they're trying to treat somebody in shock, with basically two major tenets of restoring end organ perfusion and doing ventricular unloading. And this is always keeping in mind to revascularize those patients who are also ischemic. And so we can see here in this diagram, I've chosen a heart with an impella in place. And with this impella, we can accomplish both of these things. By unloading the ventricle, we can decrease the end diastolic pressure by decreasing the wall tension, increasing the coronary flow, and ultimately improving that mismatch in oxygen demand and oxygen supply and demand. At the same time, we can perfuse all of their peripheral organs. We can maintain arterial perfusion pressure and provide coronary blood flow simultaneously. So with this type of device and a patient that may need this, we can accomplish both things at the same time. I do like to always mention the pulmonary artery catheter, and again, going back a little bit to the history here, in terms of the first understanding of hemodynamics. Back in 1929, Dr. Forsman, he introduced a catheter into his own heart, took an x-ray of himself, and showed that it was feasible to measure a pulmonary artery pressure using a peripheral catheter. But it wasn't until 1970 when Dr. Swan and Gans really developed the triple lumen Swan-Ganz catheter that we use today. And to be honest, this has not changed too much over time. We do have now the introduction of some of these continuous cardiac output pulmonary artery catheters, which can be also very useful in taking care of patients with shock. But really just to impart on everybody that the PA catheter really still plays a critical role in the diagnosis and management of cardiogenic shock. And we do have some more recent data to show that the use of PA catheters really has improved outcomes when we're looking at some of the large multi-center registries. So in this study that was published by Dr. Garan out of Boston, they looked at all the patients that were coming in with shock, and they categorized them into patients who did not have any hemodynamics measured, those that had an incomplete assessment of hemodynamics, and those who had a complete assessment of hemodynamics. And what you can see here is not only the breakdown of these types of patients, but you can see that in the gray bars, that those patients that had complete sets of hemodynamics across the board had lower mortality. And I think we all know that there's nothing therapeutic in itself of having a swan dance catheter in place, but using that information to then make decisions as to what the next steps will be with your patient, whether that is with vasoactive medications or mechanical circulatory support, or advancing them to more support that can provide more cardiac output. This is where we can see the power of using these catheters. And there's some ongoing data now going on through the cardiogenic shock working group, also trying to better understand the utilization of PA catheters and also how these can affect our shock outcomes. So why talk about shock besides the fact that I'm working in the ICU here? The fact of the matter is that this entity really leads to high mortality. And over the years, we have not seen such a dramatic change in this mortality. There was a big improvement in the late 1990s, and this was really when drug-eluting stents were mainstream, and efforts for door-to-balloon times really were put into place. And many of the patients that were coming into the hospital were getting up to the cath lab quickly. But it wasn't until more recently that we were able to make that next dent in the mortality for these patients. So ultimately, what we want to do is recognize patients early in their disease course and intervene early in order to improve outcomes. And so here, again, I demonstrate this downward spiral if we don't intervene, where we end up not just having low output and poor perfusion and hypoxemia, but leading to this cascade of systemic hypoperfusion, which leads to inflammation and multi-system organ failure. And so ultimately, if we're able to identify these patients early in their hospital course, then we can provide them with coronary reperfusion, ventricular support, and circulatory support. So when we think to our colleagues in terms of other emergency conditions, groups within stroke, trauma, and sepsis had developed ways in terms of identifying patients early. In cardiology, we too have figured out a system to identify STEMI patients early in their course as well. And this includes not just training physicians and nurses within hospitals, but this actually extends out into the public and into EMS, and being able to even identify these patients in the field and bring them to centers that can provide them with timely support. And in all of these different entities, what we can see is that through early identification, multidisciplinary teams, and then timely delivery of care, mortality and morbidity from things like stroke and trauma and sepsis decreased dramatically. So many of you know that the groups out of Detroit and Fairfax, Virginia were really the leaders in this, where they were identifying acute MI patients and providing not just door-to-balloon time, but sort of door-to-support time, putting Impellas in these acute MI patients and revascularizing them early on. And they were finding that with this type of approach, they were able to decrease the mortality from acute MI shock. And so this is really the genesis of these shock teams, which truly are multidisciplinary teams that are trying to focus on timely diagnosis, standardized approaches, and streamline care delivery. And this extends not just within a single hospital, but actually extends out through hospital networks or with other hospitals, even outside of hospital networks, being able to identify these patients and then get them to places then that can provide them with the advanced care that they may need. But as you know, it takes a village to take care of these patients. It really requires a collaboration between many different specialists, including heart failure physicians, interventional cardiologists, critical care physicians, cardiac surgeons, cardiac anesthesiologists, and perfusionists. And this goes hand in hand with the use of acute mechanical circulatory support. And really, it's through these teams that we're helping to be able to select the right device for each patient at the right time. And having an understanding of what each device does, how it's inserted, what are the complications of it, what is its anticipated duration of use. We usually come together to then make this decision as a team together. So nowadays, the toolbox for acute mechanical circulatory support is quite large, going everything from balloon pumps to different types of impellas to extracorporeal support, whether that's with the tandem devices or with via ECMO. And also, there has now been an increased number of right-sided devices that are both percutaneous and surgically placed. And so there's a variety of ways to insert devices, a variety of different configurations. And so trying to pick the right configuration for your patient, this is where the team approach can be really helpful. So with all that said, it seems like being an ICU doc seems pretty complicated. And then I'll tell you that once I took over as medical director of the CCU, I was introduced to a whole nother host of things and realized that, wow, you need to be a maverick of almost anything. You need to understand quality metrics. You have to understand teamwork within multidisciplinary teams and really figure out how can you engage all of your team members throughout the ICU to come together to take care of these complex patients. So I have to say something about hospital-acquired infections because this is central to patient safety. But working in the ICU, you need to have some knowledge of things like central line-associated bloodstream infections, catheter-associated UTIs, ventilator-associated pneumonias, and having a form of antibiotic stewardship. And understanding what are the risk factors that contribute to these things, how can you mitigate them, what type of prevention strategies you can put in place. All of these things by keeping our patients without infections that helps them in terms of long-term morbidity and mortality. And we need to keep these in mind in addition to making all of the other medical decisions for them. And if that was not enough, as a cardiac ICU physician, you also need to understand how to treat patients' pain and prevent delirium, treat anxiety and agitation, understand early mobilization programs and how to utilize those, know the latest in prevention for GI bleeding, understand how to troubleshoot the vent and prevent ventilatory complications, really push to liberate your patient from mechanical ventilation, provide proper nutrition, control their glucose, and provide palliative care. So how do we do all of this? One thing I've learned is that the partnership with nursing is key to all of this. And I go back to the first ICU back at Cornell, and Dr. Killip and Kimball wrote this, and they realized that it really wasn't until they empowered nurses and made them part of the team and just as an important part as the physicians were, that they were really able to start saving lives at a different rate than they were before. And so I've learned over the years that partnering with nurses really, that's what makes the unit run. And that's really, how we can really take care of our patients in the best possible way and get the best possible outcomes. So it really is a collaboration between many different specialties, of which MDs are and RNs are a part of, but here in like a big academic ICU, we're going to be involved with our PharmDs and our respiratory therapists, our dietitians, our physical and occupational therapists, our APPs that are working side by side with us, our speech pathologists, our social workers, and our palliative care colleagues. And it really, when we bring everybody together as a team, I think this is what gives patients the best experience and the best outcomes. So going forward, how are we going to train our future cardiologists? As of right now, you probably realize there's not an ACGME accredited cardiac critical care fellowship. But all of our fellows, really need to be exposed to cardiac critical care, have a good understanding of invasive and non-invasive diagnostic modalities, understand temporary and long-term MCS, and feel comfortable with the general management of critically ill patients. And really, this is what is accomplished at that level 1 for all of our fellows. But for us, for those people who really want to work in a cardiac ICU as a career, oftentimes this does mean getting level 3 training, which right now we're talking about doing some additional training beyond cardiovascular fellowship. There are 3 general pathways that fellows may take. The most common is actually doing a critical care medicine fellowship, which is about 1 year after they finish a traditional 3-year cardiology fellowship. The advantage of this is that you enter that fellowship with knowledge of cardiovascular physiology and hemodynamics, and you usually have the ability to focus on rotations that might be most useful for a cardiac ICU career. There are a few programs in the country that provide a 3-year integrated cardiology and critical care medicine fellowship. And in this pathway, these fellows complete 30 clinical months, of which 12 of those months are in the critical care setting. And at the end of that 4 years, they are able to sit for both critical care medicine and cardiology boards. And then finally, the last but probably least popular pathway is to do a critical care medicine fellowship up front, which would be a 2-year fellowship, and then follow that by a cardiology fellowship. And the disadvantage here is the increased amount of time, and also that you may lose some of your critical care medicine skills as you're completing through your cardiology fellowship. So, in summary, I want to all of us to just reflect on how complex our patients in the cardiac ICU are. That these patients have changed dramatically over the past several decades, and that many of them are going to require the intense expertise not only of cardiac disease, but also critical care interventions and cardiac devices. And figuring out what is the best staffing model for our current day ICUs is going to be really important for improving patient outcomes. In addition, implementing shock teams and making them part of the cardiac ICU, not only has this been shown to decrease patient mortality, but also just leads to more of this multidisciplinary approach to the modern day patient. And finally, figuring out our way of training our future cardiac intensivists is going to be really key in maintaining the high level of care that we provide to all of our patients. And so I'll end with this quote from Dr. Killick and Dr. Kimball, which really still resonates, even though this is now almost 60 years later, that the coronary care unit remains an area where the professional personnel must retain constant vigilance and a high degree of expertise for treating the emergent cardiovascular crisis. And I feel like that's something that we still see day to day. So thank you very much for your attention, and I'd be happy to share any other thoughts or answer any questions.
Thank you very much, Maria. That was excellent. Very nicely covered. Very important topic. And we have now also Dr. Michael Wang. Michael Wang is the director for our cardiac care unit. So I'll start a quick question. So I would like to understand, given that fellowship training and resident training involves certain degree of variance in how they learn and practice, how do you incorporate APP in the academic circle of care, and what's been your ratios, or how do you divide? Just give us an idea of what your CCU looks like.
Sure. So, as you kind of alluding to, I think different hospitals have done it differently in terms of incorporating APPs and the ratios you do that at. So Cornell has a little bit of an unusually large ICU. We have a 20-bed cardiac ICU, which makes it challenging to staff. So we actually have a combination of house officers, cardiology fellows, and physician assistants in our CCU. The approach that we've taken here is that we have cardiac specific physician assistants, and they rotate both in our cardiac ICU and on our cardiac step down unit on a heart failure run step down unit service. And so they really get specialized training in advanced heart failure, all of the mechanical assist devices. They're very well trained in procedures. And so by focusing this group just on cardiology as opposed to, them rotating other parts of the hospital, they become quite expert in managing, some of these patients, especially the shock patients. I think the challenge as the ICU has changed over the years is that, house officer training in internal medicine, I think it can't be the expectation that they're going to know everything about impellas, balloon pumps, LVADs. Here at Cornell, we're also a pulmonary hypertension center, which is another hat that I wear. So then expecting them to understand Remodulin and iloprost, it's just overwhelming for them. So I think the advantage of having APPs, and whether your hospital does physician assistants or nurse practitioners, is that they can focus on some of these advanced therapies, become very facile in troubleshooting them, understanding the hemodynamics that these patients may present with, and really being able to escalate things in a more timely fashion to the attending. That's what I have found advantageous. We're trying to find what that exact right ratio is. I'm not sure I would have completely achieved it here at Cornell, but for our 20-bed unit, we have 5 house officers, 2 PAs, and 2 cardiology fellows, of which one of those fellows tends to be an advanced heart failure fellow.
So let me get that number correctly. For 20 beds, you have 5 house officers, 2 fellows, and how many PAs?
And 2 physician assistants.
And 2 physician assistants. And do they stay all? What's the ratio in the morning and in the nighttime?
Yeah, so that's the daytime staffing. At night, it does go down to 1 fellow, 1 resident, and 1 PA.
That makes sense.
Which is a little bit. We're trying to change this. Especially now, you probably heard that we opened a heart transplant program here about 10 months ago. So we're now starting to change some of that up. When you look at the ratios at some of the other New York programs, it's not too dissimilar, and many of the other academic centers do have a mix of APPs and house officers in their CCUs, with the exception of one New York program actually being all APP run.
I would say that you probably have a large endowment in the morning time, so I'm jealous. But anyway, so Mike, I'm going to refer to you to your questions, and then I'll come back.
Oh, thank you so much for this very thorough and comprehensive review of the ICU and the shock team. This is exactly what myself, my heart failure colleagues, as well as just the whole program. We're trying to build a robust, cardiac ICU as well as a shock program similar to yours. Just like Dr. Sengupta was mentioning and you were mentioning, these residents, health staff, there could be going to endocrinology. So to ask them to manage these shock patients at night, it's just, it's just beyond me. But we have 1 fellow who covers the whole hospital. So that's the point I think Dr. Sengupta was trying to ask you about. Now, my question is, you have presented the AHA sort of different models. What, in your opinion, is sort of the ideal model? Should a hospital of our similar size, should we be hiring intensive care trained cardiologists? Because they're difficult to come by, and to even retain them. I know our MICU colleagues can't hire any intensivists to, stay at night. Everybody wants to work during the day. But during their fellowship interview, all the residents say, "Oh, I love the CCU. That's what I want to do." But then when they get out into training in real life, they totally change.
Well, I I'm gonna start by saying I completely agree with you. That's been my experience as well. I think that it is increasing in popularity to do both of these fellowships. It's quite a long road, but I think for some of these people that are committed, they're very hot commodities. And I think it's really hard to recruit them because there's still, in the number, I think there's only around like 100 in the whole country actually that are true board certified in both disciplines. And I think everybody is after trying to hire these folks. So I think that the more feasible, sustainable model is pairing people together. So I can just tell you that at Cornell, the way that we have done this is we pair a heart failure cardiologist with a general cardiologist together for our 20-bed unit. And I think the way that why that works for one reason is that our heart failure group here, even though none of us are board certified intensivists, we have spent such a vast majority of our time, both in training and in practice in the ICU, that we're sort of, cardiac intensivists in the spirit. Now, I don't perform bronchoscopies. I don't endotracheally intubate people. But for that, we do have our colleagues from the anesthesia team and the critical care teams that help us with that. So I think it's just being able to create a collaboration. But I think oftentimes just having one person, if they're not particularly enamored with ICU or haven't had a lot of ICU experience, then pairing them with somebody that I think is the most sustainable model for many people. And then you also can decrease the burden of the nighttime calls. We found that once we doubled up on our attendings and having the pair, then you were able to do much more ICU over the course of the year because a lot of the call at night could be split up as well.
You guys have the Impella devices in your the cardiac ICU or the CT surgical ICUs?
They're in the CCU with us.
With you, okay.
Yeah, both the CPs and the 5.5s.
5.5s. So surgeons just put it in and you monitor and take care of it. What if there's like an alarm and issues? Then you get the surgeons?
Yep. Yeah, I mean, I think it's a learning curve with everything. So to be honest, it's not too dissimilar from the CPs, and they actually alarm a lot less than the CPs do. So, but yeah, the surgeons, if there is an issue with the positioning and it needs to be repositioned, then I usually just call them. But to be honest, once you get to learn the device a little bit more, they're actually really much more user friendly, and the patients have much less complications with them. So the only things that we don't house in our CCU currently are things that really require perfusion. So the ECMO circuits and the Protect duos. Those are housed in our CT ICU, but everything else, including the durable VADs, are in the CCU.
So Mary, I'm going to scratch your brains a little bit more because you mentioned about all STEMIs, probably they can be triaged differently depending upon their risk stratification, if you would say. So what's the role of it seems like you have a step down, which is very adjacent to your CCU. And this is in my opinion, it's a very dynamic duo where you can shuffle people in and out. What's the concept there? I know that you are using that for your heart failure, but
yes.
I find that very useful for the CCU to be the team to be extended out to the step down in a way. I don't know if they're staffed differently, but having a close proximity and these two units, it allows like a continuum of care sometimes, which is not available otherwise.
Absolutely. I mean, listen, we're really lucky that actually our step down is geographically, physically located right next door to the ICU. And, in the end, I have to be honest, this comes a lot down to nursing. It really depends how you staff your step down unit with nursing. So our step down unit, we really have either a 3-to-1 or 4-to-1 patient to nurse ratio. And because of that, we're able to house many drips on our CT, on our step down unit. We can house people on Remodulin, VADs, etc. And I think it just gives you a little bit more wiggle room here. And like you said, makes you a little bit more fluid. So that patient that's on milrinone and a Bumex drip, we can push them out into the step-down unit and feel pretty comfortable with that care. But I think it's because we have actually a lot of APPs out on our step-down unit that are manning these patients who have, a lot of specialized cardiac experience. And two, that the nurses out there really are excellent. I can't underscore that, because without the nursing, that kind of setup, it's just not very feasible. But I think, our foray into housing acute MIs more on the step-down unit really happened during COVID. I mean, I think we saw all across the board on the Eastern Seaboard that the amount of acute MIs fell dramatically in 2020. I don't know if all these patients died at home or what happened to them, but because our ICUs really were reserved for these really sick COVID patients, we actually ended up housing almost all of our acute MIs on the step-down unit with a little extra vigilance. And it actually worked out pretty good. Obviously, patients who need mechanical support, mechanical ventilation, those patients still need to be in the CCU. But the vast majority of these patients come in, they might be really sick in the ED, but by the time the interventional guys, fix them up, they really can be stepped down level, and probably, pushing more of those patients in that direction opens up the beds in the ICU for the patients that really need it.
So how many percentage of your STEMIs go to the CCU versus, the real CCU care or step down? And what's your average stay of your STEMI patients? Do you discharge people from step down directly?
Yeah, so, a lot of the low risk ones, sometimes they may come just for a night in the CCU and then they'll go home either the next day or go down to the step down unit for one more day. Certainly the non-LAD STEMIs, have relatively short length of stay as long as there's not any other major complications.
All right. That confirms. I was also under the same opinion. That's the same thing we need to do here. There's no need for them to go to the floor beds because I think that creates a lot of discontinuity of care. Mike, any last question? Because I know that we are over time, but I wanted to just...
We have a million questions. Maybe I'll reach out to you. We can...
Yeah, absolutely.
Offline, to learn.
Yeah, I'd be happy to speak to whomever about shock teams, ICU. But it's really been a pleasure to speak with all of you tonight. It's super exciting to share, some of my passions with everybody else. And some of these things I just learned through, kind of trial by error, just experiencing it. And I think that a lot of cardiac ICU people have the same experience, that you sort of just like living through these changes and how you adapt over time.
Great. Thank you very much. Thank you, everyone. Have a good evening. Bye-bye.
Thank you.
Thank you.